So welcome everybody. This is the second session. This is the dry eye talk among experts. And first of all, I'd like to thank ESW Vision, all the ESW Vision team for the invitation to be here today. And we want to give you some good insights about the dry eye practice and the dry eye management. So I am with big friends here from Italy, Luca Vigo, and from Argentina, Andrés Benatti, and want to do this expert talk. And I want to begin with you, Luca. We all know that there are increased number of dry eye patients all over the world. And we have some studies. We didn't have any studies in the whole South Hemisphere until 2018. We had only studies in the North Hemisphere. You have a high prevalence of dry eye now in Brazil, according to the studies made in the University of Brazil. And I want to know about you, in your practice in Italy. You know the prevalence of dry eye in Italy or in other countries in Europe. How is your perception about dry eye today?
Thank you, Liliana. I don't know exactly the percentage, the prevalence of dry eye in Italy, but I think that is a big issue also in our country. I think it's a big issue because we have tons of people that are suffering from dry eye disease that I can check every day in my clinical practice. And also sometimes we have patients without symptoms, but they have some signs of dry eye that we have to check and to screen before refractive surgery or cataract surgery. So I think that is a big problem that we have to take care if you want to do our job in a proper way.
Thank you, Luca. And for you, Andres, the same question. Do you have any studies about the prevalence of dry eye in Argentina or maybe in other countries of Latin America?
Well, thank you, Liliana. Thank you for having me here. It's a tremendous pleasure. We are seeing much more dry eye, not just in older patients, even in young patients. We have a lot of teenagers, kids with dry eye because they spend a lot of time on the screen, on the computer, with the cell phone. So this is, we say now that it's a problem of 4 generations, right? Kids, teenager, young people, and older patients. So maybe a few years ago, this dry eye disease was a problem for older people, older patients, right? We were aware before go to a cataract surgery, but now patients that they want a PRK or a LASIK surgery, we have to be aware about the ocular surface because it's an increase in the prevalence of this pathology in this young group of people.
Yes. Before moving to another question, I want to give you some data about the prevalence of dry eye in Brazil, for example. A study that was made by the University of Campinas found 12.8% of the prevalence of dry eye in Brazil. And considering all the 5 geopolitical regions of Brazil. But in São Paulo, you know, the biggest city of Brazil, they found 24%, twice more. And among students at the university, they found twice more, 24%. So we must focus on dry eye disease. Dry eye is increasing all over the world. It's an important subject for us, not just in Brazil or Latin America or in Europe. We are talking about the whole world. People are suffering from dry eye disease, and there's an increased number of dry eye patients. So let's move to another question, Luca. We know that you are an experienced surgeon in Italy. You do refractive surgery, you do cataract surgery. What do you think, how do you prepare these patients for surgery when you diagnose a patient with dry eye disease, or if they don't have a diagnosis, they are asymptomatic, do you screen them with diagnostic tests? How do you do in your practice? You examine before, looking for signs of dry eye, and if you find signs of dry eye, you treat before surgery. How do you prepare your patient?
Thank you, Liliana. Yes, of course. I think that we need to check all our patients before surgery. We have to share to different group of patients because we have patients with symptoms and patients that are asymptomatic. We need to patient with symptoms. It is easier just to check this patient and to see if there is something wrong related to the tear film or the ocular surface. And in this case, of course, we stop any kind of evaluation, I mean, in terms of data enrolling before surgery, of course. And so we treat the patient and we ask the patient to come back when the symptoms disappear and the situation is improving or is much better than in that occasion. But also in case of asymptomatic patient, it's very important if we find out that there is something wrong related to the ocular surface and especially related to the tear film, we ask the patient to follow a specific therapy in order to improve the ocular surface before the evaluation that it is very important, of course, before the laser refractive surgery or in case of cataract surgery, especially with multifocal IOLs. I think that this is very important because we know also that all kind of anterior segment surgery may cause dry eye. And so in case of patients that are not prepared or with symptoms or signs of dry eye, it's better just to inform them, to treat them before evaluating them and before treating them. What I do what I think is very important, specifically according to the type of the dry eye that are suffering from. So I prescribe, of course, a pharmacological approach. We know what is important, sometimes also with steroid or antibiotics and so on, drops, of course. But in some cases, I also use some devices like the EI, like a IRPL treatment, because I want to restore a perfect tear film production before, as I told you, evaluating the corneal surface and doing the surgery.
Thank you, Luca. Let's follow the same idea for you, Andres. You are an experienced surgeon in cornea and in refractive surgery in Argentina. We want to know, how is your practice before the surgery? You try to diagnose asymptomatic patients. How do you do? You propose to the patients to go for image exams before the surgery or screen everybody. How do you do?
Well, before surgery, we screen all our patients before the surgery, laser refractive surgery. And as you know, we need to identify patients with symptomatic and non-symptomatic, with subjective symptoms and objective symptoms. Sometimes patients have symptoms, but you can't find anything in the, for example, tear check. Everything is okay, so you can move forward with the surgery sometimes. But most of the time, we can have subjective and objective symptoms. In those patients, we have to start a pre-op protocol, right? So once we are here, we have to define what kind of dry eye is, mild, moderate, or severe, aqua deficient, or evaporative. 80% of the cases is evaporative, so we can indicate pharmacological treatment, IPL. We have different options, of course. But it's very important to treat this patient before go to the surgery because the result will be better. And we want to have the best possible result for our patients. And the tear film, as Luca said, it's very important for these patients, for the result of the surgery, cataract surgery, refractive surgery. So that's why I recommend, so do a screen for all the patients, but not all of them will need treatment, right? But this is very important. Not always subjective and objective symptoms are the same, right?
Thank you, Andres. The answers are pretty the same. We all recognize the importance of diagnosing dry eye patients before surgery and the importance of treating them prior to any ocular surgery, such as cataract or refractive surgery or a blepharoplasty or ocular plastic surgery. It's very important to diagnose prior to any ocular surgery. And you mentioned that IRPL is an option for treatment before to prepare your patients for surgery. And among all these indications, let's talk a little bit more about these other indications for the treatment with the device of IRPL. Luca, what are the main indications? We talked about the indications for ocular surgery. Let's talk about the other indications that you choose IRPL to treat your patient.
Yes, I think that IRPL treatment is very effective in stimulating meibomian glands. So I think that I can use this device if I want to treat all my evaporative dry eye patients with meibomian gland dysfunction. Usually I try to classify my patients with meibomian gland dysfunction in different groups. One group is the patient with the functional meibomian gland dysfunction. That means that they produce less or bad quality of meibum. But there are also patients with obstructive glands, and this is what I call obstructive meibomian gland dysfunction. And in some cases, you see also some atrophy. So I think that especially in case of functional meibomian gland dysfunction, so I mean patient with poor production or bad quality production, I think that this device is really effective in treating these patients, because we know that the device stimulates the parasympathetic nerve and so stimulates the glands in order to produce more meibum and good quality of meibum. So I recommend this device in all cases of evaporative dry eye disease with meibomian gland dysfunction, especially in case of functional meibomian gland dysfunction. In case of obstructive meibomian gland dysfunction, I prefer just to disobstruct the glands before doing the stimulation. So that means that there are some devices, or also by squeezing the glands, or there are some other techniques that we can use. We can disobstruct the glands, but then I want to also to stimulate the glands using the IRPL treatment.
Perfect, Luca. So the same question for you, Andres. What are the other indications in your daily practice in Argentina? What are the other indications for our IPL?
Well, we know very well the main indication is meibomian gland dysfunction, but also inflammatory disease, rosacea, blepharitis, demodex. It's very common, so we have to check in the slit lamp this kind of patient, because most of the, I would say 50% of the patients, sometimes they have blepharitis or demodex, and IRPL is a perfect treatment for them. Refractory dry eye, when we can find a solution with pharmacological treatments, IRPL is also an option. And well, this dermatological disease, like I said before, rosacea, this patient goes very well with IRPL. We have to set and customize the treatment, the session. We can do 3 or 4 sessions, and we have to see the space, how space are there, like between 1 week or 2 weeks. But these are very good options for these patients.
Thank you, Andres. Before moving to another subject, I would like to add something to your answers. You both mentioned MGD, blepharitis, demodex, rosacea, and we previously talked about the pre-operating patients. But we must not forget about our glaucoma patients. It's a very nice indication for IRPL, because the drops destroy the meibomian glands. So we have very good results with the treatment of IRPL when we treat patients with glaucoma under drop treatments, and this drop contains BAC preservative that affects the meibomian glands. And also I'd like to add this, our autoimmune disease patients, like Sjogren, for example. Sjogren patients have aqueous deficiency, but they often will have MGD problems. So they will also benefit from the IRPL treatment. So these are the main indications for IRPL. So let's move to another subject for Luca. Luca, when do you make the decision with your patients for RIPL? When you make the final decision that the patient needs and you propose the patient the treatment?
Good question, Liliana. Usually I start using the pharmacological approach in my patients because I prefer not to push an instrumental approach at the beginning. But depends on the severity of dry eye. So if the patient complains a lot, or if the patient is really demanding. Sometimes comes to my office patients that went to other doctors, and so they know exactly what is the problem and what are the solutions. And so they know everything also because they went through the web, and so they know that there is the possibility of IRPL treatment. And so in these cases, I start immediately proposing also both the pharmacological and the instrumental therapy with the IRPL treatment. But usually in the normal, in the routine, my routine practice, at the beginning, I prefer to tell the patient, okay, start using these drops and not only, of course, artificial tears, and then you come back after 2 weeks, 3 weeks, 1 month, depending on the severity of dry eye and about of the symptoms, of course. And then I add something else that is the IPL treatment.
Perfect, Luca. So the same question for you, Andres. When do you make the final decision that the patient needs to go for IRPL treatment?
Well, except if the patient comes with an inflammatory disease like rosacea, blepharitis, or demodex, we start with IRPL is the first option. But the other kind of dry eye or mild dry eye or aqua deficient dry eye, we start with, as Luca said, pharmacological treatment, lifestyle changes, habits. It's very important for our patient education. We need to understand that education is one of the most important things that we can teach to our patient, we can give to our patient in order to improve the quality of life. But in these cases, with severe rosacea or blepharitis, my first option at the beginning is IRPL. Yeah.
Perfect, Andres. Before moving to our final question, I would like to add that you are correct when you said that you begin your treatment with clinical treatment, and you are correct when you indicate to your patient for the first time IRPL. So both of you are correct. So there's no an exception for that. You can initiate your treatment with clinical treatment and together with IRPL. There's no need to wait for the patients to get worsened. If you have a moderate dry eye, it's mandatory if you have the technology to indicate the best for your patient. So don't wait until this patient gets too much worse. So,
Can I
yes,
say something?
please.
I think there is no a rule. We have to customize every patient and every treatment. It's impossible to say for all my patients I will do this. We have to see every patient as with a customized treatment.
Perfect, Andres. To wrap up, we are going to move to our last question. It's about chalazion treatment with IRPL device. I know Luca Vigo is one of the pioneers in the world with this kind of treatment, and I would like to know that are you using this protocol? How is your protocol for chalazion treatment with IRPL device?
Yes, I had this idea to use IRPL to treat directly chalazion some months ago, probably 1 year ago, because I know that this device and this treatment is effective in, of course, reducing inflammation. And so we know also that it goes deeper into the skin, into the glands. And so why not to use this directly on the chalazion, that is a chronic inflammation inside the gland. And so what I did is asking for specific masks that could highlight specifically my chalazion. So we put the gel on, and we put a corneal shield, because in this case the risk to go deeper and also for the cornea to be damaged is higher. And so I started treating this kind of patient, because you know that the patients with chalazion, yes, they have to follow also a clinical approach, a pharmacological approach using steroid, tetracycline, and so on. But sometimes takes time to have an improvement, and so these patients are not they don't want usually to have a surgery for chalazion, and so they prefer to do anything they can in order to avoid this kind of surgery. And so in these patients, usually I started using, of course, the pharmacological approach, so I prescribe ointments and so on, but also I suggested to use the IRPL treatment. The protocol that I'm using now is 4 sessions, 1 per week, and so I have the patient like for a standard IRPL treatment. So I have the patient with lay the patient on a bed. I let the patient prepare by my optometrist. So I use the mask. I put the corneal shield inside after some drops of anesthetic drops, of course. I put the corneal shield, and then I check which is the best mask that I can use in order to highlight the chalazion and covering all the other part of the eyelid. Then I put the gel on the chalazion, and I do 3-4 flashes directed on the chalazion. And I repeat this procedure once per week for 4 consecutive weeks. And the results are quite good. I'm going to present the first results on my first patients this night. But I think that it can be an option, a good option. And also I suggest, since this patient have an obstructive meibomian gland dysfunction, because we know that chalazion is an obstructive gland. I think that we can use both the standard protocol, I mean the IRPL protocol, in order to stimulate the gland, and the chalazion protocol in order to improve the situation and to treat the chalazion. And so this is what I do. I usually combine the 2 protocols, the one specific for chalazion and the other one, the standard one, for treating the meibomian glands, and I have really good results.
Excellent, Luca. We are experiencing some IRPL treatment for some patients in Brazil too, and I will let you know my results. So, Andres, did you have any experience in Argentina with this kind of protocol to treat chalazion?
We are just starting with the protocol following the master, Luca. He's the pioneer on this protocol, so we are starting with the first patient. We are having good result. I think it's a great option in order to avoid surgery. We started with 2 sessions of IRPL, and after that we see how is the evolution of the chalazion. But I think it's a great tool for this patient, and even when as I just said, the patient doesn't want to go to the surgery, right, to the OR. So it's a great option, and I'm excited to see the results of the master tonight, and maybe we can bring this option to Argentina, of course.
of course, I think it will be another very good indication for IRPL in a very short period of time. So